Hello, my name is Ariel, and today I'm going to be presenting my capstone project that asks the question: in patients with a diagnosis of active non-segmental vitiligo, how do JAK inhibitors as compared to placebo repigment patches of vitiligo? So just to start with a little background of vitiligo, it is believed to be an autoimmune type of condition where there is milky white, well-demarcated patches of skin depigmentation. It affects a lot of people, approximately 1% of the general population. It can affect any gender, any age, people living in any location. There is no known cure for it, but some treatments include topical corticosteroids, calcineurin inhibitors, or topical JAK inhibitors. This diagnosis does not affect mortality, but there are some social and psychiatric effects that can affect quality of life for these patients, especially in women, children, and those with darker skin complexions. So the exact pathogenesis of vitiligo is unknown, but this is kind of the strongest idea of how it may possibly work. So it's believed that some people have immune cells that are kind of overactive and melanocyte specific, and they end up infiltrating borders of depigmented lesions and then further destroy melanocytes via the JAK-STAT pathway. And so the idea behind JAK inhibitors as a class of drugs is that they would act on that process and control the pathway that's believed to be overactive. And so that would prevent further depigmentation from happening. So the purpose of this presentation is to report upon the 3 articles that I kind of compiled to relate to my PICO question in terms of the use of JAK inhibitors in treating vitiligo. And then also I'll be comparing oral JAK inhibitors to the currently FDA-approved topical JAK inhibitors. So one of the tools that all of these articles sort of use to measure vitiligo and its progress over time is the Facial Vitiligo Scoring Index, or the F-VASI score. So basically, it's where the patient would measure the lesions of depigmented skin using their fingertip, and that would be equal to a certain percentage of body surface area, and then when entered into the F-VASI formula, they would have their F-VASI score. And then over time, if that F-VASI score is decreasing, that means that there is repigmentation occurring. So the goal would be an F-VASI score. So how I kind of chose my articles, it started with choosing a condition that I wanted to learn more about. So I chose vitiligo, and I was interested in its treatments that were currently available and treatments that are on the rise, and maybe there would be potential for another FDA-approved treatment of vitiligo. So after applying some filters, there were not that many results, but I noticed that there was really only one result regarding oral JAK inhibitors. And since topical JAK inhibitors are FDA approved, that's kind of what sparked my interest in this. So I also used Access Medicine to get the full text of some of those articles that weren't available on PubMed. And then I chose articles based on those that use similar tools of measurement, similar methods, similar primary and secondary endpoints, so that they were easier to compare. So the first article I chose is based on a topical JAK inhibitor. So it's called ruxolitinib cream. And the aim of the study was to measure at least a 75% decrease of the F-VASI score by week 24. So that would be called the F-VASI 75 response. So it was a double-blinded, vehicle-controlled trial, and some of the inclusion criteria is that the participants had to be greater than 12 years old, and they needed depigmentation covering less than 10% of the body surface area. And then some exclusion criteria is complete leukotrichia within any facial lesions, confounding dermatological disease, previous JAK inhibitor therapy, other therapies within 12 weeks, immunomodulating treatment within 4 weeks, and topical treatment within 1 week. And then the sample size was 674 participants, and that was split into 2 different trials. So how the study worked is that participants were randomly assigned into a 2-to-1 ratio of applying either 1.5% ruxolitinib cream or the placebo twice daily for 24 weeks to all vitiligo areas. And then from weeks 24 to 52, everyone could apply that topical treatment. So the independent variable would be either receiving the ruxolitinib cream or placebo, and then the dependent variables would be that F-VASI response, T-VASI response, which is just the total scoring index, and then the vitiligo noticeability scale rating, which is kind of a self-reported rating. And then the study found that about 30% of those receiving the drug achieved that F-VASI 75 response at week 24, and that number rose to 50% by week 52. The main adverse events that patients receiving the drug had were mild to moderate application site acne and pruritus, and then also nasopharyngitis. The next article that I chose was once again a topical JAK inhibitor, same cream, ruxolitinib cream. The aim and the methods are largely similar. The inclusion criteria, the age rose to 18, but once again, it had some certain criteria about body surface area. And then exclusion criteria, pretty much the same, although this also excluded patients with abnormal thyroid levels, cytopenia, low platelets, neutrophils, and lymphocytes. The sample size was 157, split into 5 different groups, so a little bit smaller than the previous one, but still had statistical power. And so patients were basically assigned to one of 4 dosing strengths of ruxolitinib or placebo. So that's kind of the main difference between the first trial and this one, is that there were different dosing strengths. So that was for 24 weeks, and then for the next 28 weeks, anybody that was not improving on the lowest strength or anybody on placebo could be assigned to any one of the higher strengths. And then after week 52, everyone could receive the highest dose. Everyone could receive optional phototherapy for 104 more weeks. So the independent variables, pretty much the same, but now also the frequency and concentration of ruxolitinib also changed between the groups. And then dependent variables, once again, F-VASI, T-VASI, and then facial physician's global vitiligo assessment, which is one of their secondary endpoints. Didn't focus too much on that. And then similar results as well. So a greater proportion of patients receiving ruxolitinib cream achieved the F-VASI 50 response in a dose-dependent manner. So F-VASI 50 is basically the same thing as F-VASI 75, except instead of a 75% change from baseline, there is a 50% change from baseline. So just not as big as a jump for what the results measured. Similar adverse events, application site, pruritus, and acne. And then the last article I chose was about an oral JAK inhibitor. So it's called oral ritlecitinib. And once again, aim of the study is the same goal there. Similar methods, similar inclusion criteria and exclusion criteria. The sample size is 364, split into 6 different groups. Patients were randomly assigned to one of 5 treatment groups or placebo for 24 weeks, and then there was also an extension period, depending on their response, for an additional 24 weeks. Independent variables, once again, medication being administered, dosing. This regimen of treatment also included some loading doses in some patients. Some patients did not receive loading doses. Dependent variable was the F-VASI response, and then the study found that a significant percent change in F-VASI in treatment groups receiving 50 milligrams ritlecitinib with or without loading dose in the dose ranging period as compared to placebo at week 24. And then some adverse events for that, this is where it's a little bit different. This drug caused nasopharyngitis, upper respiratory tract infections, and headache. So definitely more systemic effects, as you can expect with an oral drug. So moving on to the discussion. So just to revisit the PICO question, the question that I started with, yes, so across all studies, there are significant repigmentation with the use of JAK inhibitors, and since topical JAK inhibitors are already approved and oral JAK inhibitors show similar efficacy, it could open the door for oral JAK inhibitors being FDA approved with further research, of course. And then when I was comparing topical JAK inhibitors to each other, I found it interesting that in Article 2, it actually demonstrated a greater change in the F-VASI response when the same concentration of cream was applied once daily instead of twice daily, as compared to Article 1 by week 24. But then by the end of the study, the drug that was administered twice daily ended up creating a greater F-VASI response. I just thought that was interesting. Might be worth looking into a little bit more. A topical drug like a JAK inhibitor would not create as many side effects like application site pruritus and acne if it's not applied as often. So it could be worth looking into if there is some potential for the drug being applied once daily to be equally as effective as applying it twice daily. And then sort of the question that I was coming to as I was going through this is, can systemic medications avoid dermatological side effects associated with the topical JAK inhibitors? And if so, would it even be worth it? Because topical JAK inhibitors, as I've said before, can create that topical site irritation. The medications that are already on the market, corticosteroids and calcineurin inhibitors, can also cause skin atrophy and striae. So taking an oral medication would completely avoid that route. And when we think about what we're treating, vitiligo, it is a skin condition. It's a condition that often makes people feel uncomfortable in their own skin and feel self-conscious about how their skin might look. And so if they're being treated with a drug that can potentially help the depigmentation, but then also cause more skin conditions, that might be worth looking into a change for and discovering different avenues for the treatment of vitiligo. Also, the oral JAK inhibitors were found to be more effective in treating areas of the skin that are harder to heal, like the hands and the feet. And also, an oral drug would avoid some of that human error that comes with applying a topical treatment to yourself on a daily basis rather than taking a pill. It's a little bit more exact. And the other thing to consider with oral JAK inhibitors compared to topical is that topical treatments you can really only use if you have depigmented lesions already. And so when you're looking at a systemic drug, could there be a world where this drug actually ends up preventing further patches of vitiligo from developing instead of just treating the ones that already exist? And so this kind of discussion sort of guides where future research might be able to go. I think that the side effect profiles of systemic JAK inhibitors should definitely be studied more. It's not a benign drug. It is an immunomodulating drug. It makes people more prone to infections. So that's worth looking into as well, and risk versus benefit for that. I think lengthier trials with larger sample sizes would be needed, as well as for any new research. Having more data to back up the conclusion you're trying to reach is important. And I think one of the biggest things that would be important for future research is to create studies where there's more diversity. So vitiligo does not affect people of fairer skin tones more than darker skin tones. It affects anybody equally. And all across these studies, they kind of mentioned that one of their weaknesses is that most of the participants had fair skin tones. And while the pathophysiology is believed to be the same for all skin tones, it's still not quite known. And I think that it would be a disservice to our patients with darker skin tones if we say this treatment will be just as effective for you as those with lighter skin tones if there's no study to really back that, no evidence to really back that. And it's important because these patients face more psychiatric and social effects when it comes to vitiligo because it's just more visible on darker skin tones. And so I think this is definitely a very important part of future research, and just being more inclusive with the participants for the studies. And then also there should be more head-to-head trials comparing topical and oral JAK inhibitors to each other. I can't really conclude that one would be better than the other if it's not kind of pitted against each other with the same inclusion and exclusion criteria and all the different variables that go into a study. That would be important in order to reach a conclusion of whether oral JAK inhibitors are just as effective or better, or just what the outcome would be if they were placed against each other. So these are my references. And that concludes my presentation.